gives me great pleasure to welcome Dr. Jean-Michel Arnal, who's going to be talking with me today with regards to his current practice of management of patients with COVID-19. He's part of the anesthesiology and intensive care unit, along with being in charge of the home mechanical ventilation centre in the Hôpital Saint-Mus in Toulon, France. He's also an organizer of Les Ateliers de Ventilation à domicile. So thank you so much for talking to me today. And rather than me tell people what your practice is like and your hospital, I'd love it if you could just give me a little bit of an insight into where you work.
Thank you, Michelle. Very nice to talk to you. So I'm anesthesiologist by education, and I work in an ICU. It's a 24 beds ICU, and because of COVID, we had to extend to 35 beds. So this is half of my work. The other part of my work is to take care of home ventilation unit, so on a regular basis.
Fantastic. So how are things now compared to the first wave at your centre?
Well, in the first waves, most of the patients, around 70% of the patients, were intubated. And as you know, they were ventilated for 2 to 3 weeks with a lot of complications. At that time, we were very reluctant to use non-invasive ventilation or high flow because first, we were afraid to spread the virus to the caregivers. And also, we treat this patient as normal RDS, as we did before for non-COVID RDS. Now, in the second wave, we realized that COVID RDS is different than non-COVID RDS, and that non-invasive support is quite efficient, and we could use it and push the patient a little bit further with non-invasive support. So in the second wave, that was in last November and December, we dropped the number of intubated patients from around 70% to 28%. And with this, of course, the mortality rate dropped also from 25 to 20%. And the length of stay, I don't have the precise number, but obviously the length of stay also decreased. Now we are the third wave, and the third wave is quite interesting because it's a different case mix. Third wave for us is younger patient with less comorbidity, and it seems that the intubation rate is even lower than the second wave. So currently, the intubation rate is around 10%, and the mortality is going to be quite low.
Because you're having less intubated patients now, is your ICU full of the sickest patients and you're managing patients on non-invasive aids outside the ICU? Or is it that your ICU has capacity to manage those patients as well?
Well, actually both. I mean, we started a sort of intermediate care unit in the pulmonology ward where they can provide high flow, which was not existing before the COVID pandemic. But still, we admit patients in the ICU for non-invasive management, because what I call non-invasive is a combination of high flow, awake-prone position, and CPAP. And so it's very intensive, actually, in terms of caregivers. We need as much nurses as for normal ICU patient, intubated patient. So we prefer for this patient to admit them in the ICU with the same number of nurses and physicians for a short period of time, usually it's 7 days only, so very intensive treatment, and then they improve quite rapidly and they can move to the
And with these patients, you've said that the treatment is very intensive. Are they needing any CPAP, oxygen, or high flow therapy to go home, or have they recovered enough to go home basically breathing on air?
Yeah, no, they go home without any of these treatments.
Yeah,
In the worst case, little bit of oxygen, but for a short period of time.
That's interesting, because we were discharging patients like that in way back, almost like in a month's time. But as you've explained, your therapy is now more intensive and shorter. It's good that they're getting to the same point without having to prolong treatment almost into the home environment to help discharge. Now, you've spoken about using CPAP therapy, oxygen therapy, and high flow therapy outside the intensive care. When you see a patient, do you look at them and think you're going to need high flow therapy, you're going to need CPAP, or do you have an algorithm that you assess patients? Could you tell me a little bit more about how you choose what therapy each patient should have?
To be honest, when I see a patient, I don't know which patient will benefit from CPAP or prone position. So we have a sort of protocol that all of them get high flow. And then we try from the beginning CPAP and prone position. And we measure which one is more efficient in terms of oxygenation improvement. But we ask the patient, what do you prefer? To spend the night in supine or to with a CPAP, or to lay in prone with a high flow? And most of the time, the patient are able to say what is more efficient. I'm not able to tell it, but they're able to say, and they, of course, they choose also what is the most comfortable for them. And I let them choose. And it's very interesting to see that some of them prefer CPAP, and it can be sometimes very efficient, and some of them prefer prone position.
And you've obviously had a vast amount of patients requiring CPAP therapy and those that are requiring high flow therapy. Obviously, we would always tune therapy to the patient. But if you had to think about the group as a whole, is there, for example, an average CPAP pressure? Is there an average for high flow flows that you need an oxygen, just so that people that are less experienced with this, although I appreciate everyone has skilled up very quickly, but is there some average settings that can be applied, or is it definitely still individualized?
No, well, for high flow, we use always 60 liters at the beginning, because as you know, the oxygenation effect of high flow is due to the flow. The more flow you provide, the more oxygen you provide. And we adjust FiO2 to target an SpO2 between 90 and 94. That's our standard protocol. And then when the patient improves, we first reduce FiO2 down to 40%, and at 40%, we start to reduce. Regarding the temperature, we use always 37 degrees. For the CPAP, we use 10 of pressure. At least we set 10 of pressure on the device, depending on the mask and so on. I'm sure that we get 10 all the time. And the same, we adjust FiO2 to target 90 to 94% of SpO2.
And with regards to the devices you're using, are you using devices that are walled or oxygen blending devices, or are you using more portable devices that are targeted for the high-end home mechanical ventilation?
Well, actually, we use both, because we have a shortage of CPAP device. Suddenly, a lot of patients need CPAP, and we were not prepared for that. So usually what we do is that we use wall devices at the beginning when they need high FiO2. And then as soon as we can use CPAP with lower FiO2, then we turn to portable device, because on those portable device, most of the time you cannot reach 100% FiO2. And the good point is that when we switch to portable device, we use a home care mask, which is much more comfortable than what we have in the hospital. So the patient usually is happy to switch to portable device.
And those patients that have been self-proning with using home masks and even the hospital CPAP masks, are they comfortable doing that? Or do you find that because of the mask, they may be swapped onto high flow or oxygen for that, or can they tolerate CPAP and proning well?
Well, CPAP and proning is an extreme. Usually we don't mix both because it's quite difficult to be proning with CPAP. It's possible, but it's a little bit uncomfortable because of the mask that is moving. So usually when we do proning, we do it in high flow. And when we do CPAP, it's...
So often it may be useful if you're having a patient, do you have them that are switching between CPAP and high flow, or do they tend to be just on one therapy? Because sometimes CPAP can only be worn for a certain period of time, and you think, I'm not sure you're going to do as well just on oxygen. I might want to give you something in between.
Yeah, of course, we mix. I mean, I tell to the patient every 4 hours, you have to spend 2 hours either in CPAP or in supine, and they decide. And during the night, the same, they have to use either prone position or CPAP, and they decide what they prefer. So it's quite intensive because for the nurse, every 2 hours, they have to change the treatment.
Definitely. There's been lots of treatments that have been proven to be beneficial, not just CPAP, high flow therapy, intubation and ventilation. There are pharmacological treatments. If you had to pick one treatment, what would you say is the most changing for a patient if you had to give it to them?
Steroids. Steroids for sure. I mean, when we started to use steroids, I guess it was in May, after the discovery study, we saw obviously the change in the outcome. I really believe that the respiratory support is just to buy time or to prevent further complication. But CPAP or high flow is not treating the COVID pneumonia. What treat the COVID pneumonia or decrease inflammation is steroids until we have more other treatment.
Yeah, I think we've learned a lot and we've got lots more tools to manage these patients. Just thinking forward, because this doesn't seem to be going away anytime soon, is there something missing? Is there something apart from the wonder drug that cures it or the pandemic stopping? Is there anything else that you can think of for people out there that is useful or that we do need, that perhaps we can utilize?
Well, in terms of equipment, I have the feeling that there are not so many CPAP devices dedicated for ICU use.
Yeah.
So we realize that in the future, this would be nice to have this sort of CPAP device. Also, one need that appears with the COVID is be able to remotely set a ventilator, meaning, as you know, each time we want to change FiO2 or PEEP, we have to enter the room to get dressed and so on. So if we could remotely set the ventilator, that would be very nice. And finally, again, for the manufacturer, we are currently testing closed loop oxygen system, either on high flow or on low flow oxygen. There are several companies that enter this market, and using closed loop oxygen system brings a lot. meaning that you set target SpO2 and the ventilator or the machine will adjust the FiO2. And this is really interesting in many aspects because you learn also from your patient.
Definitely. And also that kind of automated system has a big effect, especially if your hospital is running short of oxygen.
Absolutely. Yeah.
Definitely. Thank you so much. It's been wonderful to talk to you. So many tips and so much information. I'm going to go away and take on board bits and pieces and put it into my practice. So thank you so much.
Thank you, Michelle.